بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنتكلم عن الهايبر and الهايبومagnesemia. Hypo and hypermagnesemia as part of acid and acid-base electrolyte disturbance. أولا بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما. صدق الله العظيم. اللهم صل وسلم على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. هنبدأ بس بالسلايد ديت. إيه relationship between hypomagnesemia and other electrolyte disturbance. Other electrolyte disturbance like hypercalcemia, hyperphosphatemia, metabolic acidosis, either whatever the cause, either diabetic ketoacidosis, starvation ketoacidosis, all this will potential risk factor or causes for hypomagnesemia. If I have one patient with hypercalcemia or hyperphosphatemia or metabolic acidosis, this will be potential cause or risk factor for hypomagnesemia. And then same time, any patient with hypomagnesemia should look for hypocalcemia and hypokalemia, the potential complication of this hypomagnesemia. لما يبقى عندك الخلاصه من السلايد ديت، انت لما يبقى عندك هايبومagnesemia لازم تشوف الكالسيوم، تشوف الفوسفورس، تشوف الاسيد بيز بتاعك، وتشوف البوتاسيوم في العيان ده. introduction. طبعا البرزنتيشن كله عموما مساعده الاسيد بيز electrolyte disorders text book of دكتور محمد تيناوي and دكتور كامل and I just summarize as I can from previous lectures and books from Dr. Tinawi. The magnesium introduction. For magnesium is the second most abundant intracellular cation. يبقى المغنيسيوم ده تاني أكثر عنصر موجود داخل الخلية، أو ده ملح موجود داخل الخلية. It's a major factor in numerous cellular function. طبعا major cofactor. طبعا ده بيستخدم عامل مهم جدا في السيلولار فانكشن على all over the cell in our body. Magnesium is a cofactor in hundreds of enzymatic reaction. Magnesium is essential for cellular energy production because it's a cofactor for ATPs or adenosine triphosphate Krebs cycle. Magnesium metabolism is linked to potassium and the calcium metabolism. لما تلاقي hypomagnesemia or hypermagnesemia, you should look for potassium and the calcium metabolism also. Hypomagnesemia is associated with severe chronic disease. لما تلاقي عيان عنده مرض مزمن وكده، لازم هتلاقي عنده عنصر المغنيسيوم قليل such as insulin resistance, hypertension, and osteoporosis. Severe hypermagnesemia associated with significant toxicity. Magnesium can be easily replaced oral or IV. It's easy to manage any patient with hypomagnesemia either by magnesium sulfate IV or magnesium oxide as oral tablet. Disorder in magnesium or magnesium metabolism are overlooked at time because magnesium is not included in routine chemistry panel. انت دايما ما تطلبش المغنيسيوم، لازم الدكتور يبقى عنده high suspicion to request magnesium if you found hypocalcemia, hypokalemia, whatever. You should include the magnesium as an order recommendation in your blood work. Magnesium is the fourth most abundant cation in our body and is the second most abundant intracellular cation. يبقى هو fourth يعني رابع أكثر cation in our body and the second cation in intracellular after البوتاسيوم. Normal cellular magnesium concentration between 1.7 to 2.7 milligram, 2.6 milligram per deciliter, or 1.4 to 2.2 milliequivalent per liter, or 0.7 to 1.1 millimole per liter. This is international unit. We are using this 0.7 to 1.1 millimole per liter. To convert from millimole to milliequivalent, just multiply by 2. This is the valence of magnesium atomic weight. To convert from millimole to milligram, millimole to milligram, just multiply by 24, the atomic weight of magnesium, and divided by 10. If you have to convert from millimole 2 milli equivalent, multiply by 2, and convert from millimole to milligram, just multiply by 24 and divide by 10. Intracellular magnesium concentration around 8 to 10 millimole per liter. The intracellular magnesium concentration 8 to 10 millimole per liter. Free intracellular magnesium is around 0.6-0.8 millimole per liter. Most of intracellular magnesium is bound to ATPase and the enzyme. The average daily intake around 360, around 15 millimole per day. Daily intake around 360 milligram, is equal 15 millimole. 120 milligram is absorbed in the intestine, mostly in the small intestine, and to a lesser extent in the colon. About 20 grams excreted with the intestinal secretion. So the net absorption now is 100 milligram, which equals the amount excreted in urine by kidney. The remaining 260 is excreted in stool. The daily intake around 360. I will excrete in the fecal 260, and another 100 milligram will be excreted in urine. So your body now in a steady state from intake and excretion. From this intake around absorption 120 milligram and secretion 20 milligram. Need daily magnesium uptake by our blood compartment or intravascular around 100 milligram. The bone containing 12,900 milligram, muscle 6,600 milligram, and other tissue for 4,900 milligram. The kidney do infiltration around 2,400 daily, absorption 2,300 milligram daily, and the difference between filtration and absorption is around 100 excreted in urine. But now we are daily, just to remind, intake around 360, 260 excreted in the fecal, and 100 excreted in urine. And the total magnesium in average body weight 70 kilogram is around 24 grams. And 70 kilogram, 24 grams. About 52% of total body magnesium in the bone, 52, around more than 50 now in our bone, 27 on the muscle, and 20 in non-muscular soft tissue. Magnesium is stored in the bone. بيتخزن فين؟ موجود في البون in structure component of hydroxy apatite. ده احنا قلنا ده المادة الأسمنتية اللي بيحصل منها الكالسيوم فوسفات and المغنيسيوم بتدي الصلابة أو strength of our bone. Hypomagnesemia and low dietary magnesium intake is associated with osteoporosis. Hypomagnesemia اللي عندهم نقص في المغنيسيوم with low dietary intake of magnesium دول بيبقى عندهم risk for osteoporosis اللي هو وهن العظام بتاعنا. Extracellular fluid contains only 1% of total magnesium. Serum contains only 0.3% of total magnesium, most of it in the red blood cells. This is our distributions, as we mentioned, 52% in the bone, and 27% on the muscle, and 20% on soft tissue mainly, and only 1% in extracellular fluid, just 52% in our bones. Magnesium in the bone does not immediately equilibrate with serum magnesium. Actually, that exchange takes place over several weeks. Any loss of magnesium, for example, due to diarrhea or diuretic, comes from extracellular fluid volume magnesium, fluid magnesium. The kidney adapt by lowering the amount excreted in urine. The fraction excretion of magnesium 3-5% in normal individual is equal to 3-5% in normal individual. It can be lowered 10 times to 0.5% of the extrarenal hypomagnesemia. So one moment. Yes. The mission fraction excretion of magnesium is 3-5% of normal individual. It can be lower 10 times to less than 0.5% of the extrarenal hypomagnesemia, less than 0.5%. If you will calculate fraction, if you have refractory resistance hypomagnesemia, and you will ask it for 24-hour urine magnesium, creatinine also, and with the same time serum magnesium and creatinine, and you will calculate your fraction excretion. If less than 0.5%, this means extrarenal, either from GIT loss or another causes we'll discuss now. Serum magnesium may not reflect the total body magnesium, which around 60% of free ionized magnesium, free, and 10% is complex bound to anions like citrate, phosphate, bicarbonate or sulfate, and only 30% is albumin bound. As we mentioned, ionized 60%, this is a free magnesium in our blood, and 10% complexed with citrate and phosphate and sulfate, and 30% albumin bound. In small intestines is a site of absorption of our magnesium in small intestine paracellular between cells, only in the late jejunum and in the ileum. Late jejunum and ileum is a site of absorption of magnesium. In the colon, both transcellular via RPM 6 and 7 and paracellular. But this is a site in the colon for transcellular means this need ATP. محتاج energy عشان يحصل له transcellular absorption in the colon, and also can be occurs paracellular. RPM that channel already are a mammalian transient receptor of potential melastatin non-selective cation channel. This is the name of this channel. Diarrhea fluid contains significant magnesium, 15 milliequivalent per liter, while vomiting contains only 1 milliequivalent per liter. But diarrhea now is the main cause of hypomagnesemia, contain around 15 milliequivalent per liter, while vomiting contain only 1 milliequivalent per liter. The kidney, the kidney proximal convoluted tubule just here reverse. This is special only for magnesium. Only the proximal tubule 20%, and thick thinning limb around 60 to 70% reabsorption of magnesium. These already this in comparison by the previous electrolyte like sodium, potassium, calcium, whatever. The only magnesium now in the proximal convoluted tubule reabsorption around 10 to 20%. Via these paracellular routes, according to the concentration gradient, and in thick ascending limb also around 60 to 70% absorption paracellular, passive diffusion, no energy requirement, and the claudin 16 is a protein and interact with claudin 19. Both are tight junction protein between the cell, forming cation selective tight junction complex that facilitate magnesium transport. The process is dependent on transepithelial voltage. The distal collecting tubule absorbing now 5 to 10% via active transcellular route, and also dependent on membrane potential. The remainder 3 to 5% filtered magnesium is excreted in urine. Just only 3 to 5% excreted in urine. Most of the magnesium excreted occurs during the night following circadian rhythm. And this only picture or slide, you will see the distribution of magnesium different from other electrolyte. In the proximal convoluted tubule absorbed 10 to 20% of the filtered magnesium. Lobe of Henle absorbed 60 to 70% of the filtered magnesium. Distal tubules absorbed only 5 to 10%, and 3 to 5% already filtered or excreted in urine. Now 10 to 20% proximal tubule, 60 to 70% thick ascending limb of thin descending limb of lobe of Henle, and distal tubule 5 to 10%, and this 3 to 5% already filtered on the magnesium. This shape you will see only in magnesium. The difference between reabsorption of proximal convoluted tubule and the lobe of Henle. This claudin, the protein making this tight junction, claudin 16 and 19 paracellular between these two cells, and this sodium potassium 2 chloride channel, wrong channels, and this every ipsilateral this side of the blood vessels here, and this is the lumen of the tubules or the urine. We have sodium bases will reabsorb 3 cation of sodium and and will shift in replacement with the sodium to potassium ion, and this calcium chloride channel also. Magnesium reabsorption is thick ascending limb via paracellular routes. The thick ascending limb, not the descending limb, around 60-70% of reabsorption is thick ascending limb via this paracellular routes. The process is passive and dependent on sodium potassium in uptake via sodium potassium 2 chloride pump room channel in the renal outer medullary channel also. The mentioned before, daily intake of magnesium, just to remind you, is 360, 160 fecal excretion, 100 urine excretion. Thick ascending limb and distal convoluted tubule absorption. Factors that increase in magnesium absorption in the thick ascending limb. Patient with hypomagnesemia, this need more reabsorption. Patient with metabolic alkalosis. Patient with amyloid active distal convoluted tubules. Factor that decrease magnesium absorption is thick ascending limb. Patient with hypermagnesemia, no need for magnesium, metabolic acidosis, loop diuretic, thiazide diuretic, hypokalemia, hypophosphatemia, hypercalcemia. All this causes lead to hypomagnesemia and decrease absorption of magnesium. Either patient with hypermagnesemia, metabolic acidosis lead to hypomagnesemia, loop diuretic, thiazide diuretic, hypokalemia, hypophosphatemia, hypercalcemia. Hypercalcemia activate calcium sensing receptor in the basolateral membrane of thick ascending limb and subsequently decrease magnesium and calcium reabsorption in thick ascending limb, resulting in hypermagnesemia and hypermagnesuria and hypercalciuria. This via this calcium sensing receptors from hypercalcemia. Both magnesium and the calcium bind to a calcium sensing receptor on parathyroid gland and the kidney. However, each had this distinctive binding site. As I mentioned before, this calcium sensing receptor have binding site for magnesium, for calcium, for phosphorus. Magnesium play a role in parathyroid hormone modulation. Unlike calcium, there is no hormonal. Just one moment. Parathyroid hormone pH modulation, unlike calcium, there is no hormonal system that significantly affect the magnesium metabolism. Acute hypomagnesemia stimulate PTH secretion, and hypermagnesemia suppress PTH secretion by acting on a calcium sensing receptor. It's important to note that profound hypomagnesemia suppress rather than stimulate PTH secretion and increase PTH resistance and upon leading to hypocalcemia. Hypomagnesemia may result in recalcitrant or refractory hypokalemia from hypomagnesemia. This is because magnesium inhibits roncate channels, therefore hypomagnesemia increases potassium secretion in the collecting duct. Why this will be happening? Because the hypomagnesemia acts as the guard on the roncate channel, renal outer medullary channel, prevent loss or escape the magnesium to urine. The magnesium and the calcium, just one moment. One number. As we mentioned, sorry for interruption, I have just a phone from emerge. The magnesium acts as an inhibitor of the calcium in our body. Magnesium antagonizes the calcium-dependent acetylcholine release at neuromuscular junction. Magnesium is anti-apoptotic, while calcium is pro-apoptotic. Serum level of calcium and magnesium may not represent total body content. Both cation exist in three forms, either free or ionized or albumin-bound. With both magnesium or calcium, just either free in our blood or ionized or albumin-bound, and the complexity to anion. The body contains 24 grams, about 1,000 grams of calcium. For 24 grams of magnesium, يبقى عندك 24 جرام من المغنيسيوم and around 1 gram or 1.2 grams of calcium in our body. Severe hypomagnesemia can lead to severe hypocalcemia, hypocalcemia secondary to pH suppression and increased pH skeletal resistance. It's recommended that adult male consumes 400 to 420 milligrams of magnesium daily. For adult females, the recommended amount of magnesium 300 to 320 milligrams daily. And it should increase to 350 400 milligrams daily during the pregnancy. The recommended amount of magnesium during the breastfeeding around the same 300 360 milligrams daily. Magnesium is the central element in chlorophyll and play a critical role in photosynthesis also in our vision. Magnesium is rich food include muffin, who's the diet rich in magnesium, the green vegetables, seeds such as cashew and almond and brown rice and nuts. Other good source of magnesium include cereals, black potatoes with skin, oatmeal and yogurt and banana, black beans and peanut butter. Processed and refined food is a poor source of magnesium compared to refined foods. Increased consumption of processed food is resulting in decreased magnesium intake, especially in Western world. الإجابات السريعة. Normal serum magnesium, as I mentioned before, I am using the last unit millimole per liter, 0.7 to 1.1 millimole per liter. By milligram 1.7 to 0.6 milligram per liter. Magnesemia less than 0.7 millimole per liter or less than 1.7 milligram per deciliter. Significant signs, symptoms seen when serum magnesium less than 1.2 or less than 0.5. Hypermagnesemia more than 2.6 milligram per deciliter or more than 1.1 millimole per liter. And you will see significant symptoms and signs when exceed 4.8 milligram per deciliter or 2 millimole per liter. Magnesemia is seen in hospitalized and the community dwelling subject. This is the common, you can see common, you see many patients, especially in kidney transplant patients, you will see many patients with hypomagnesemia. Hypermagnesemia is less, you can see in dialysis, you can see some patient on chronic kidney disease with chronic constipation taking many laxative contains this magnesium. A study of about 5,000 community subjects aged between 55 years and older. This is a Rotterdam study found that hypomagnesemia divided as magnesium is 1.2 milligram per deciliter in 2.4% of individuals between 55 to 64 years, and in about 1.8% in individuals aged more than 65 and older. Hypomagnesemia in the same study was associated with increased adjusted mortality risk of 1.39. Is a high risk also for this hypomagnesemia associated with high risk, and they will see one study in ICU also. Japanese study measured serum magnesium in 6,000 plus inpatient. Hypomagnesemia less than 1.5 milligram was seen in 2.6, and hypermagnesemia more than 3.9 milligram was seen in 0.8%. Hypomagnesemia is more common than الهايبرمغنيسيميا. hypermagnesiemic patient either had impaired renal function, بيبقى عندهم مشاكل في الكليه, while on magnesium containing antacid, other some containing magnesium antacid, diuretics, laxative, or where women treated with magnesium sulfate in the course of preeclampsia or eclampsia. Hypomagnesemia is common post-operative intensive care concentration. Study on 193 such patients found hypomagnesemia less than 1.5 milligram per deciliter in 61% of our patients in ICU or in hospital. Evaluation, diagnosis of magnesium metabolism disorder require high index of suspicion because of magnesium. Not all doctors request magnesium in the routine lab. You should put in your mind to request magnesium if you have hypokalemia or whatever, any dyskalemia or dyscalcemia or dysphosphatemia. You should put magnesium in your mind. Serum magnesium measurement is readily available, but it may not correlate with the total body magnesium because only extracellular contain just only 1% of the total magnesium. Maybe we can use refractory hypomagnesemia. You can measure 24-hour urine magnesium creatinine with serum magnesium and creatinine and check the fraction excretion of magnesium. And this magnesium load, I think, when using this magnesium load, the aim of this load to give high dose, either 7.5 gram or 5 gram loading magnesium, either IV or oral. And if a patient who secrete more than 60 or 7% from this loading test, this will be unlikely secondary to magnesium deficiency. If the patient secretes more than 60% are unlikely to have magnesium deficiency. Magnesium loading test is rarely used because it's both false negative, also in diabetic, alcoholic, false positive in patient with CKD. This picture, hypomagnesemia, magnesium 7 markers or characteristics for hypomagnesemia. Malnutrition symptoms, maybe you'll find with your patient with hypomagnesemia, malabsorption, patient with GI problem, patient with metabolic acidosis with dialysis or renal failure. Just think on that. Patient with alcoholism, loop diuretic thiazide, patient with tetany, patient with muscular excitability and the treatment. You should think also just watch for confusion, depression, irritability, and nystagmus. Any criteria from this criteria or 7 criteria or more in patient in emerge or in clinic or in hospital, just thinking to check magnesium. And this summarizes causes of hypomagnesemia, either from redistribution, especially revealing syndrome, acute pancreatitis, post-parathyroidectomy, intravenous dextrose, correction of diabetic ketoacidosis. All this can lead to this hypomagnesemia. Extrarenal excretion, as we mentioned, the most important one is diarrhea. Secrete around 15 or 16 millimole or milliequivalent per liter. In comparison, bile vomiting just only 1 millimole. Intestinal or biliary fistula, profound sweating, burn, sepsis, lactation, also nasogastric suction. Increase intake by alcoholism, especially in cirrhosis, malnutrition, small bowel resection, malabsorption also. From decrease intake, either from redistribution, extrarenal loss, mainly diarrhea, decrease intake, malnutrition, malabsorption, renal loss, ketoacidosis, saline osmotic diuresis, potassium depletion, phosphorus depletion, familial hypophosphatemia, tubular interstitial renal disease. Drugs, especially loop diuretic thiazide, diuretic, and aminoglycoside. Aminoglycoside lead to hypomagnesemia, amphotericin lead hypomagnesemia, vitamin D intoxication, hypomagnesemia, alcohol, cisplatin, thiophylline proton pump inhibitors, calcineurin, cyclosporin, tacrolimus, all lead to hypomagnesemia. Endocrine SIDH also, hyperthyroidism, hyperparathyroidism, hypercalcemic states, and as we mentioned before in the first slide, hypercalcemia can lead to hypomagnesemia with hyperphosphatemia, also hyperthyroidism, SIDH, primary or secondary aldosteronism. Hypomagnesemia can be dietary deficiency, malnutrition, patient على TBN, redistribution, especially hungry bone syndrome, severe hypophosphatemia, hypomagnesemia, hypocalcemia with hungry bone syndrome after parathyroidectomy for tertiary hyperpara or refractory secondary hyperpara. GIT illness, especially chronic. I think this is the most important slide for any patient with hypomagnesemia. اذا البيشنت ما بياكلش كويس عنده مان نيوتريشن، عيان على تي بي ان ممكن تظبطه في التي بي ان، عيان عنده هانجري بون سيندروم، عيان عنده كرونيك دايريا، عيان عنده مال ابزوربشن or renal wasting like loop diuretic patient على loop diuretic thiazide, aminoglycoside, Bartter Gitelman syndrome. Chronic treatment with proton pump inhibitor, this will down regulate this channel as I mentioned before, this TRPM6 channel. We mentioned the name before. This which is chronic PI, an important cause of hypomagnesemia. You will see this secondary to magnesium decrease in intestinal absorption because down regulation of this receptor. TRPM6 channel, maybe this MCQ examining MRCB or whatever. Don't forget this PPI in our hemodialysis patient. You will check a monthly lab for your dialysis patient. You will find hypomagnesemia. You just check this because decrease in intestinal absorption from down regulation of this TRPM6 channels or regulation. This summarize the hypomagnesemia either from dietary deficiency, malnutrition, TPN, chronic alcoholism, gastrointestinal, chronic diarrhea, proton pump inhibitor, malabsorption, laxative, small bowel syndrome, intestinal fistula, nasogastric suction, primary infantile hypomagnesemia, renal wasting, diarrhea, loop diuretic thiazide, diuretic phase of acute tubular necrosis, post-obstructive diuresis, Bartter-Gitelman syndrome, aminoglycoside, cyclosporin, antichrolimus, epidermal growth factor receptors inhibitors such as cetuximab and cisplatin, amphotericin B, pentamidine, foscarnet, and baturumir. This is a potassium binder. We'll come to dysmagnesemia later. Congenital or acquired tubular redistribution, acute pancreatitis, Hungry bone syndrome, refeeding syndrome, blood transfusion, insulin. This all causes of redistribution. Endocrinology, primary and secondary, aldosteronism, hyperthyroidism, hyperthyroidism, diabetes mellitus, SIDH syndrome, inappropriate antidiuretic hormone secretion. This summarize causes of hypomagnesemia. I note put this slide in your mind: either dietary deficiency, either GIT problem, renal wasting, either drugs related or renal related, especially. Patient was post-obstructive ATN, loop diuretic, Bartter-Gitelman, amyl oxide, cyclosporin, cisplatin, amphotericin, pentamidine, and foscarnet, baturumir, and redistribution and endocrine causes. Drugs, just to remind the drug with corticosteroid, alcohol, thiovelin, amphotericin B, insulin, this diuretic. This just summarize. We have genetic magnesium disorders that originating in the kidney, in the thicker thinning limb or distal convoluted tubules. Genetic GI causes hypomagnesemia like TRPM6 gene mutation is very rare. Example of genetic hypomagnesemia and thicker thinning limb include Bartter syndrome type 1, 2, 3, 4, and familial hypomagnesemia with hypercalciuria and nephrocalcinosis type 1 and 2. Bartter syndrome characterized by sodium wasting, hypokalemia, metabolic alkalosis, hypokalemia, metabolic alkalosis, high renal and aldosterone level, defect protein level depending on the type. It's partin in type 4 Bartter syndrome. Familial types 1 due to defect in Claudin 16. Familial type 2 is due to defect in Claudin 19. Both types are associated with nephrocalcinosis and renal failure. Only type 2 is characterized by ocular abnormalities. This is familial hypomagnesemia with hypercalciuria, nephrocalcinosis type 1 and type 2. Familial hypomagnesemia, hypercalciuria, and nephrocalcinosis type 2 characterized by these ocular abnormalities in comparison by this type 1. Okay. Another genetic hypomagnesemia and distal convoluted tubule, Gitelman syndrome, defect in the sodium sodium chloride co-transporter channels, characterized by hypokalemia, metabolic alkalosis, and hypocalciuria. Hypokalemia, metabolic alkalosis, differential diagnosis, hypocalciuria. Hypomagnesemia with secondary hypocalcemia due to defect in TRPM6. With isolated recessive hypomagnesemia also affecting epidermal growth factor. In this magnesium deficiency symptoms, signs, muscle cramp, muscle pain. Any patient came to emerge with muscle cramp, muscle pain, fibromyalgia, headache, migraine, GIT disorders, fatigue, tiredness, high blood pressure, irregular heartbeat, any arrhythmia. This arrhythmia should rule out electrolyte disturbance, any dysmagnesemia, dyskalemia, dyscalcemia, dysnatremia, and insomnia also. Here magnesium is lower than 1.7 or less than 0.6 or 0.5. That they will see this neuromuscular manifestation, tremors, tetany, seizure, maybe weakness, maybe apathy, maybe in delirium, coma, and prolonged QT, any hypo, prolonged QT interval, especially corrected one, widening QRS complex, atrial and ventricular dysrhythmia, hypokalemia, renal potassium wasting, abnormalities of calcium metabolism like hypocalcemia, hypoparathyroidism, parathyroid hormone resistance, decreased senses of calcitriol. This again the summarize of the symptoms of magnesium deficiency: tiredness, exhaustion, headache, migration, sleep disorders, terminal restlessness, anxiety, increase irritability. شوف حكمة ربنا في عنصر اللي هو المغنيسيوم لما بيقل بيحصل ايه في الجسم؟ عنصر واحد: stomach cramp, nausea, constipation, diarrhea, muscle cramp, and tension in shoulders, palpitation, dysrhythmia, already menstrual irregularities, cold hand and feet, tingling. Also, maybe this is the cause of you are giving multivitamin for our patient, including this magnesium, zinc, and other for this symptom. And the symptoms of hypomagnesemia depend on the severity. Hypomagnesemia can result in hypokalemia and hypocalcemia. Don't look for hypokalemia alone or hypocalcemia alone or hypomagnesemia. You should check panel of this electrolyte screening. Some patients may be non-specific symptoms, nausea, vomiting, anorexia, neuromuscular, as we mentioned before, many neuromuscular hyperexcitability. This includes tetany, cramps, weakness, dysphagia, and the muscle fasciculation. Also, sophistic signs like hypocalcemia. They mention generally fatigue and anxiety, loss of appetite, muscle weakness, memory problem, nausea, tremors, difficulty of swallowing, irregularity or heart dysrhythmia, agitations, psychosis, depression, tremors, vertigo, nystagmus, may reach to delirium, encephalopathy, seizure may be seen, cardiac dysrhythmia and emergency, especially ventricular arrhythmia, torsade, deep point, and supraventricular tachycardia. Also enhance sensitivity to digoxin toxicity. Hypomagnesemia also associated with the numerous chronic complication, osteoporosis, migraine. This is a longer-term complication, osteoporosis, migraine, increased insulin resistance, hypertension, asthma, and atherosclerosis. With again the same symptoms: anxiety, weak osteoporosis, low energy, weakness, inability to sleep. Patient عنده insomnia, you should rule out hypomagnesemia, and hormonal imbalance, irritability, nervousness, headache, abnormal heartbeat, as we mentioned, dysrhythmia. You should rule out any cardiology patient with any dysrhythmia, cardiac dysrhythmia. You should rule out hypomagnesemia, hypokalemia, hypomagnesemia, and muscle tension, cramp, seizure, also fatigue. And what is how diagnosis? Diagnosis need high or require high index of suspicion because the magnesium not included in routine chemistry, and you should check calcium and potassium together. Magnesium is readily available in lab. Magnesium really done to do loading test. Fraction excretion magnesium differentiate either renal or GIT was like a fraction excretion of potassium or potassium to create ratio to exclude or differentiate between deficient renal wasting or GIT wasting. I am using this only in the refractory cases. If fractional excretion magnesium more than 4%, this means renal loss. If less than 2%, this means GIT loss. Normal 3 to 5%. Less than 2 GI, more than 4, this renal loss. And 24-hour, maybe you'll differentiate. Calculate that. Another electrolyte disorder medication review is critical. Any electrolyte should review medication for that. ECG, to check any cardiac dysrhythmia if you suspected tachycardia or bradycardia. If genetic hypomagnesemia is suspected, specialist consultant require genetic testing for diagnosis. For sad point, just to summarize what is the causes or the most common causes of our drugs can lead to this torsade points and other electrolytes. As drugs, we have tricyclic antidepressant, disopyramide, burkinamide, phenothiazines, lithium, quinidine. All this lead to torsade point and prolonged Q2 interval and sudden cardiac death, hypomagnesemia, hypokalemia, hypocalcemia, hypothermia, subarachnoid hemorrhage, intracranial hemorrhage, hereditary long QT syndrome. What is your treatment for hypomagnesemia? Serum magnesium does not reflect total body magnesium. Patient with low normal magnesium are supplemented with magnesium, either oral or IV. Just if with patient start to be symptomatic, the patient hypokalemia, hypocalcemia, and the cardiac dysrhythmia, you should manage all this. And we have only two forms: either to give oral magnesium if the patient mild symptoms, or just give IV magnesium boluses. I usually for me I give in 2 gram IV. 100 either normal saline or half normal saline, whatever. 45 water. Don't I give in over 1 hour or 2 hours, and we can repeat that if needed, maybe ID every 12 hours or every 8 hours. The underlying cause, don't forget in preeclampsia and pregnancy, giving 1 gram or 2 gram per hour. Don't be afraid to give magnesium. At least to be safe side, if you don't have monitor like that, just give over 2 hours. The underlying cause of hypomagnesemia should be addressed, either dietary, increased magnesium dietary intake, but this is the rule of dietitian. Many clinicians added spironolactone and amiloride to loop diuretic or sazide diuretic to mitigate this hypokalemia and hypomagnesemia. لما تضيف الالدكتون potassium sparing and amiloride is potassium sparing diuretic and also magnesium sparing diuretic at the same times two other loop or sazide diuretic have a good role also. We can treat as you mentioned by oral magnesium oxide. We can give 400 a tablet. We can give TID or BID, but take care from diarrhea. You should follow your patient or just the side effect of magnesium. This will help this patient with constipation. You will treat constipation and you will treat hypomagnesemia. If the patient in cardiac dysrhythmia or seizure, you should give IV magnesium at least 2 grams and repeat it as needed. We have several magnesium formulation, but the most common one is magnesium oxide. Just so don't form this diarrhea. Nausea, vomiting is most common adverse effect. The diarrhea is the most common one after magnesium. The most common formula I am using magnesium oxide is around 400 milligram capsule or tablet. I'm using just to start BID or TID if simple symptom. Other form I think I am not using, I don't have experience with that, you can read later. If persistent hypomagnesemia in hospitalized patients, this is a trick here, and the nephrology will intervene here with persistent hypomagnesemia in hospitalized patient require the IV magnesium because oral magnesium replacement is limited by diarrhea and poor bioavailability. Magnesium chloride, magnesium lactate availability 12%. But I like magnesium oxide has a bioavailability around 4%. Magnesium sulfate, this is the only form of using IV. I'm not using intramuscular. We can give 2 grams, especially in patients with severe cardiac dysrhythmia or seizure. Magnesium sulfate is a 10% solution, 1 gram per 10 ml. I am just usually giving 2 grams. Each 1 gram of magnesium sulfate contains 98.4 of elemental magnesium milligram, 90 or 8 milliequivalent or 4 millimole. يبقى 900 ممكن 884 800 خلينا كده تقريبا around 800. يبقى each gram magnesium sulfate around 800 18 or 88 milligram elemental magnesium, 8 milliequivalent, 4 millimole. Be easy to remember, yeah. Typical dose in stable patient, I am usually giving 2 grams over 30 minutes or 1 hour. A higher dose, 2 to 4 gram over 4 to 12 hours is appropriate in patients with severe low magnesium, less than 0.4 or less than 1 milligram per deciliter. Serum magnesium should be monitored and dose is repeated dose until normal magnesemia and achieve this slide for our colleague in ICU or cardiology or CCU. Or we are dealing with critical patient in emerge. Just give 1 to 2 grams over 30 to 60 minutes. هتدي 1 ل 2 جرام من المغنيسيوم IV over 30 to 60 minutes, and I can give 4 grams, another 4 grams over 4 to 12 hours to patient with severe hypomagnesemia. The problem with this magnesium, just check the blood pressure because it's vasodilator and may will lead to severe hypotension. If an unstable patient with seizure cardiac dysrhythmia, I will give 2 grams IV over 15 minutes, followed by magnesium sulfate drip at 3 to 20 milligram per minute. يبقى لو انت عندك عيان ديسريزميا او سيجر مش بريكلامسا بقى، عيان تاني بعيد عن البريكلامسا. البريكلامسا لها مانجمنت لوحده هنتكلموا عنه. هتدي 2 جرام اوفر 15 minutes وبعدين تمشي 3 to 20 ملغ. هتبدا من 3 ملغ وكان انكريس to 20 ملغ according to frequent monitoring. For example, 10 gram magnesium sulfate, 1 liter dextrose in water infused over 24 hours. ممكن تدي 10 جرام like اللي يشوف الهايبركالسيميا الهايبوكالسيميا before. We'll come to that presentation in future. But ممكن نحط 10 grams magnesium sulfate in 1 liter 5% D5 water and do infusion over 24 hours would provide 6.9 milligram of magnesium sulfate per minute. Magnesium sulfate drip is discontinued once normal magnesemia achieved. With hyperclampsia, hypomagnesemia, and we'll come to this scenario with severe preeclampsia and the complicated by seizure and started magnesium sulfate infusion, and we'll come to that. For treatment of preeclampsia, magnesium sulfate is a drug of choice to prevent seizure in women with preeclampsia. High dose of magnesium sulfate are utilized. We can give 60 gram IV, 60 gram IV over 20 minutes. 60 gram, not 1 gram or 2 gram. انت بتبقى خايف وانت بتكتب 2 gram و 1 gram والكلام ده كله. يبقى 60 gram bolus over 20 minutes, followed by continuous infusion 1 to 2 gram per hour. This we assure you when you prescribe 2 grams is nothing for your patient. In preeclampsia, severe preeclampsia presented with severe preeclampsia admitted to the hospital, severe hypertension, I will give 60 gram IV over 15 to 20 minutes, followed by 1 to 2 gram per hour. Such high doses result in hypermagnesemia. You should follow that. Target magnesium level is not well defined, and wide range of reported clinical studies either from 4 to 8 milligram per deciliter or 2 to 3 millimole. 4 to 8, 2 to 3, or 4 to 8, or 2 to 4, or 4 to 2 millimole per liter. I need but just to remind the target either 4 to 8 milligram per deciliter or 2 to 4 millimole per liter. Just a slide just for management of preeclampsia. And this will do balance between maternal and fetal status, mild preeclampsia, just admission and observation, and you can give magnesium 2 grams per hour. Yeah, just this protocol already just to show you how you can deal with this patient with severe preeclampsia, magnesium sulfate, intrapartum, postpartum, labetalol, hydralazine, IVDB. Delivery طبعا the main definitive therapy for any patient with preeclampsia before the patient went to eclampsia. Eclampsia definitive management is delivery. لو عيان في seizure, just don't forget with mild preeclampsia I will deal with this like this. We'll start admission, betamethasone, magnesium sulfate, the assess your vital. Severe preeclampsia I will do this. Seizure I will do this. And the follow-up, I will do this. Maybe we'll continue magnesium infusion even after delivery also. Just in treatment of preeclampsia, hypermagnesemia, you should follow up with your patient. It's rarely to be having, except the patient with acute kidney injury or sticky disease will aggravate this hypermagnesemia toxicity. It's important to note the review data. The stoic showed the lower magnesium target is than 4, less than 2 millimole per liter, maybe adequate to seizure for seizure prevention. يعني الليفل بتاعك التارجت بتاعك يكون 4 milligram per deciliter or less than 2 millimole for adequate seizure prevention. Magnesium sulfate is relatively contraindicated in patients with myasthenia gravis because magnesium inhibits release acetylcholine. From that, in patients with myasthenia gravis, contraindicated to give him magnesium sulfate because this will inhibit release of acetylcholine. And that's another diagram for hypermagnesemia in patient taking magnesium as antacid. With a TKD patient, this will end by and depression, nerve function, and neuromuscular instability, and will lead to ended by this hypermagnesemia. It's causing patient with renal failure or excessive intake of magnesium-containing antacid. This will start to be nausea, vomiting, muscle weakness, hypotension, bradycardia, and respiratory pressure, not from CKD, but from this magnesium toxicity. Hypermagnesemia is less common than hypomagnesemia. You are rare to see patients with hypermagnesemia. We see those patients in CKD patient estimated for stage 5, less than 14. We concomitant magnesium salt as a laxative or citrate or hydroxide or antacid aluminum magnesium hydroxide. This is the cause of hypermagnesemia mainly in CKD patient and the patient taking antacid or laxative containing magnesium. Significant hypermagnesemia is likely even in patients with intestinal disease without exogenous magnesium intake. Hypermagnesemia common in elderly to increase the prevalence of CKD. Should, as mentioned before, serum should be routinely monitored in hemodialysis patients who take magnesium carbonate or phosphate binder. Note that sodium bicosulfate magnesium citrate is used as a bowel prep agent. Hypermagnesemia is intentionally induced in patients with preeclampsia to prevent seizure. Hyperreflexia ممكن تشوفهم طبعا في عين البريكلامسيا لما انت عملت تديلهم ميديكيشن عشان تمنع السيجر. Hyperreflexia may signal impeding eclampsia and mandate immediate initiation of IV magnesium sulfate. Some clinicians use normalization of hyperreflexia in women with preeclampsia and an indication of adequate seizure prophylaxis magnesium sulfate. Other cause of hypermagnesemia is milk alkali syndrome. Patient take a large amount of TAMS, calcium carbonate, or calcium containing magnesium also, and hemolysis, patient with tumor lysis syndrome, rhabdomyolysis, it's from intracellular compartment, diabetic ketoacidosis, lithium therapy, metastasis, familiar hypocalciuria, hypocalciuric hypercalcemia, and Addison disease. The main ingredient in Epsom salt is magnesium sulfate. Epsom salt has an element of magnesium containing 10% content and has a bioavailability of 4%. Should not be used as a laxative without physician consent, and it should not be ingested for weight loss or detoxification. Etiology of hypermagnesemia, as we mentioned, are symptoms from 2 points. From I like you can use a milligram, but I like 1 millimole per liter, 1.1 to 2, usually no symptoms, and 2.1 to 2.9 miles of nausea, vomiting. These are symptoms according to the degree of hypomagnesemia, vomiting, dizziness, weakness, drowsiness, diminished deep tender reflex. That started signs of hypermagnesemia. If your patient in preeclampsia start to be nausea, vomiting, dizziness, weakness, drowsiness, decreased tender reflex, these are signs of toxicity. 3 to 5 millimole per liter. You start to be urine retention, lethargy, alias, flushing, sleepiness, blurred, confusion, loss of deep tender reflex, loss, not diminished. Deep tender reflex will be lost. More than 5, flaccid paralysis, respiratory depression, apnea, low blood pressure, bradycardia, complete heart block symptoms. This is the most important slide for ICU and the obstetric department. How to diagnose hypermagnesemia by measuring the serum magnesium in the clinical by your suspicion and your request in clinical blood work. There is no rule for urine magnesium measurement in hypermagnesemia, and the ECG should be in the severe hypermagnesemia if cardiac dysrhythmia is suspected. You should request laser basic chemistry, use calcium and potassium. all sorts of exogenous magnesium should be discontinued as a first line of treatment of hypomagnesemia. Stop any oral intake for more than 60 with mild or minimal symptoms. Simple observation, just observe your patient, no intervention. Magnesium eliminate half-life around 20 hours. You can check in daily basis, not every 12 hours or 8 hours, except in severe with continuous infusion. Patients with severe hypermagnesemia are monitored in telemetry unit. If a patient with severe hypermagnesemia, more than 3 millimole, 3 to 5 millimole per liter, this patient requires treatment with calcium gluconate as needed, calcium gluconate or calcium chloride as antagonist as needed. Lithium antagonize the effect of magnesium on myocarditis to stabilize likely issue for hyperkalemia. Calcium utilizes similar fashion in hyperkalemia due to the CCG changes. Come to some cases, 52 presented nausea, dizziness, weakness, muscle cramp, hypertension, and also with gastritis. She's on pantoprazole 40 daily. This will do inhibition for magnesium reabsorption. And amlodipine, pantoprazole, medication for 7 years, chemistry. Benel was obtained significant for potassium 3.3, magnesium 1, calcium 7.7, album 4. What is the theory of this symptom? Severe hypomagnesemia, chronic use of pantoprazole. This leads to GI magnesium loss, decreased absorption, or because down regulation of RPM6 channel. Hypomagnesemia leads to post hypokalemia and hypocalcemia. Another case, 35 woman, gravida 1 bara 0, diagnosed severe preeclampsia with hyperreflexia on exam. It started with magnesium IV, seizure as a seizure prophylaxis. He given load in 6 gram IV over 30 minutes, followed by continuous infusion 3 gram per hour. 5 hours later, she became lethargic, unable to urinate, deep in the reflex absent. This is now magnesium toxicity. Magnesium sulfate was discontinued, and she started on 9 normal saline, treating hypermagnesemia, hyperkalemia. Normal saline is have a main role in management, followed by 1 gram calcium gluconate, IV, 5 minutes ECG, and remarkable serum magnesium level back to 7.4. Magnesium sulfate is a drug, shows a seizure prophylaxis in preeclampsia, and should be under monitoring to decrease the handle examination and the clot and the monitoring to avoid the magnesium toxicity. Case number 3, 56 man in the seasonal disease, came to emergency by lethargy, confusion, blurred vision. Given him dialysis 5 years, his family reported that he's using a variety of counter medication. He is many medication for severe constipation, and طبعا including this magnesium. How to manage this patient? The patient ingesting large doses of milk of magnesia, the active ingredient magnesium hydroxide, and then the thing develop magnesium. Patient within the seasonal disease easily to develop magnesium toxicity. Magnesium reach 8.3 milligram, ECG, no significant abnormalities, giving just normal saline 1 gram calcium gluconate, normal saline calcium gluconate, like mean hyperkalemia also. Since he's already in hemodialysis and dialysis access already readily available, he was emergency dialysis done 4 hours and magnesium came 4.8. He was instructed to avoid any magnesium containing laxative or antacid. And the 2 consultant nephrology prior to starting this medication. Around 70 years, a man with chronic systolic heart failure, ejection fraction 20%, magnesium is low, and lisinopril, furosemide, blood pressure, optimal serum creatinine is okay, potassium low. What is the most appropriate for treatment? Hypokalemia, hypomagnesemia, I will give for this patient to improve mortality. I will give this spironolactone. Discontinuation of or reduction in Lasix not good for this patient. We will go to heart, this patient heart failure. You can't stop Lasix for him. Supplementation of oral potassium, magnesium, salt will significantly increase the number and the frequency of his medication. البريد اللي هو بتاع الهارت فيلير او مع المشاكل الثانيه دي بيبقى على بولي فارماسي. No need to increase his medication. Just for clinic systolic congestive heart failure with low ejection fraction, spironolactone here. This is the key here. Spironolactone in this case, 25 milligram daily was started to mitigate this hypokalemia and hypomagnesemia resulting from his low diuretic. Spironolactone decrease the morbidity and the mortality in patients with severe heart failure. Don't forget this message. Any patient with hypokalemia and hypomagnesemia in cardiology, my cardiology colleague, just don't forget this. This case, this was heart failure. Just we are using this Pentolasics and the low ejection fraction. Just to control his hypokalemia, hypomagnesemia, please add the spironolactone, 25 only daily. That's good? Okay. Cardiology. A 60 years old woman with a history of CKD stage 4, secondary to diabetic nephropathy, by nausea, dizziness, muscle cramp, fasciculation, medication on glimepiride and atorvastatin, lisinopril, furosemide, and patyromere. This is a new potassium binder, and will come hyperkalemia again. Dyskalemia presentation will summarize all this. Was started due to hyperkalemia resulting in from increased lisinopril dose. What is the next step? Chemistry panel order: creatinine 3.1, potassium 4.9, magnesium 1. Symptoms due to hypomagnesemia, patrimony bind both potassium magnesium. In this patient, CKD stage 4, the use of patrimere allowed her to continue lisinopril at optimal dose. Furosemide aggravated hypomagnesemia. In this case, patrimere was continued and the patient was supplemented just only by magnesium oxide twice daily. I can't stop patrimere because I need this ACE or ARB to protect her kidney function. Just I will continue with magnesium oxide. I will give 400 as I mentioned for you. You will start 400 twice daily. If tolerate, you can increase to three times per day. Other case, 7 years old girl presented with evaluation CKD, comprehending muscle cramp, fasciculation, polyuria, polytepsia, with a significant UTI infection and severe myopia. Hair growth already was growth retardation, corneal calcification, this is type 2. Don't forget type 2, you remember? Familial hypomagnesemic hypocalcemic type 2. Magnesium 1.2, calcium 9, fraction excretion, magnesium is 15%, urine calcium was elevated, and intact parathyroid hormone also elevated, renal ultrasound showed nephrocalcinosis. What's your diagnosis? Familial hypomagnesemic hypercalciuria with nephrocalcinosis type 2. Only in pediatric, if this is just exam question, maybe it will come for you. The ocular abnormalities only in this type 2, familial hypomagnesemic with hypercalciuria and nephrocalcinosis type 2. We'll see this ocular manifestation اللي هي ocular calcification, corneal calcification, the genetic disorder due to mutation in tight junction Claudine 19. That's a detailed history including about relation between her parent. This patient exhibit many characteristics of this type 2 and genetic disorders. Genetic testing required by specialist. And summary, just about this diagram for you. If you like to take this sheet for you to put in your units, just summarize hypomagnesemia and hyperkalemia. This by RP via sciatography. This is a good sheet just to give you a reference range for magnesium and normal, hyper, and hypomagnesemia risk factor. What is the cause of hypomagnesemia? All causes, either medication or diseases, and hypomagnesemia manifestation all summarized here, and hypomagnesemia, how we can intervene with this patient, and this cause of hypermagnesemia, the mention, and this is manifestation of hypermagnesemia and this hypermagnesemia intervention also. Home message: diagnosis of magnesium metabolic disorder requires high index of suspicion because most of our colleagues not requesting magnesium in the routine lab. And the hypomagnesemia and hypermagnesemia present with a variety of non-specific manifestation. You should check also potassium and calcium with this. Hypomagnesemia is an important cause of refractory hypokalemia and hypocalcemia. Hypermagnesemia is less common than hypomagnesemia. Hypomagnesemia is common and this in patient with advanced CKD or exogenous magnesium oxide. لما تشوف حاله هايبر مغنيسيميا تفكر في حاجتين اثنين، ما في ثالث. either advanced CKD or patient taking exogenous either laxative or antacid magnesium. Or the intoxication. Magnesium can be replaced easily via either oral or IV. ما عندناش اللي هم الاثنين، يا اما تدي IV magnesium sulfate يا اما تدي oral magnesium oxide. Severe hypomagnesemia is serious electrolyte disorder that required emergency treatment with IV calcium. انت لو جالك عيان سيفير هايبرمagnesemia في الطوارئ هتحله ازاي؟ تحل مشكلته ازاي؟ نورمال سلاين وكالسيوم جلوكونات زيه زي الهايبركاليميا، بس الهايبركاليميا برضه بتتعالج بالنورمال سلاين، وده distal delivery to sodium to the distal nephron. Sodium will be absorbed via linatic channels, and this lead to increase in negativity in the lumen. This will exacerbate potassium secretion via wrong channels in the complete tubules. But any hypermagnesemia treated with electrolytes need normal saline and the calcium gluconate like hyperkalemia. Cisplatin and hypomagnesemia. Just put this slide just to show you how cisplatin induce hypomagnesemia through renal toxicity, possibly either from direct injury. لأن دايما السؤال ده يقول لك إيه what is the mechanism of cisplatin and hypomagnesemia, either from direct injury to a mechanism of magnesium reabsorption in an ascending lobe of Henle as distal tubules. إما from direct injury نعمل direct injury للسيك ascending limb and distal tubules for reabsorption المغنيسيوم. You can read this, and this we just will summarize what is the mechanism and what is the side effect of hypomagnesemia. This is a good article for you to read. This is another article, the Association of Magnesium Abnormalities in Intensive Care Unit in the kidney outcome and mortality. This is a prospective cohort study. This just concludes that hypomagnesemia, but not hypermagnesemia at ICU admission associated with AKI development. On the other hand, both hypo and hypermagnesemia was associated with higher mortality risk, especially hypomagnesemia. You can read this article for more information. And this is just a slide I found in social media just to summarize the magnesium, normal range, and how you can diagnose hypo, hyper, and hypo. Hypermagnesemia, just don't forget excessive dietary intake, excessive laxative or antacid intake, patient with CKD. Don't forget this. No patient over-treated iatrogenic by preeclampsia, Addison disease also. Symptoms of muscle weakness, headache, loss deep tendon reflex, ECG brady, cardiac hypotension, this as ECG changes. Hypomagnesemia either decrease intake, chronic alcoholism, prolonged diuretic use, SIDH, hypocalcemia, pancreatitis, toxemia of pregnancy, with muscle changes, tetany, seizure, like symptoms of hypocalcemia, altered mental status, hallucination, psychosis, depression, and positive troso and chauvinistic signs. The troso signs, when you elevate the cuff above systolic blood pressure, you'll find this Carver-Tan syndrome. This troso signs, and when tapping here in the facial nerve, you will find this changes by chauvinistic signs, like this is for hypocalcemia. For just a fraction excretion of magnesium to diagnose to GI loss or renal loss, and they just summarize GI loss from diarrhea or redistribution, other loss from renal lobe diuretic barter nephrotoxins or Gentleman syndrome. And these symptoms, according to the blood level, as we mentioned before, more than 20 milligrams is asystole and test, more than 50 is by depression. And with we started by dysrhythmia from 5 to 8 milligrams, is just nausea, vomiting, flushing, hyporeflexia. And with how to can manage, as we mentioned, you can read this list oral or IV, as we mentioned before. But if severe symptoms, they will go to IV direct. Low serum magnesium less than 1. If no, just oral magnesium is enough. If severe and symptomatic, I will give 2 grams magnesium and will continue infusion, especially if towards deep point. I will give magnesium sulfate and continuous infusion also. In cardiac dysrhythmia, you can read, and this is just all available formula of magnesium. I am just using for this magnesium oxide. And did the diagram again to summarize. You can put in your units or ALS unit or CKD clinic or patient with hypomagnesemia. and risk factor and management and hypermagnesemia and risk factor and management. Just to refresh your one slide, you can put this in your clinic as to remind you at least to exclude the most important cases with your patient in clinic. You can take this picture and put beside you in your clinic for dyslipidemia and dysmagnesemia, whatever hypo or hypermagnesemia, how you can deal, because most of us, because we are not dealing with this topic too much, just maybe you will forget the causes. Just to remind you by the causes, symptoms, and how you can manage and how you can deal. Now we finish. وأتمنى رب تكونوا استفدتم. وطبعا all this summarization of Dr. Muhammad Tinawi lectures and talks. Thanks for Dr. Muhammad for this nice summarization and discussion and explanation for this topic acid-based light disturbance. ونسأل الله أن يجزي عنا كل خير ونسألكم التوفيق والسداد والنجاح إن شاء الله. ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونلقاكم بفيديو قريب إن شاء الله. والسلام عليكم ورحمة الله وبركاته.